what about the myth that psychiatric hospitals is only for crazy people and only for those that are extremely violent and dangerous?
I think that's so unfortunate. And sadly, I hear that when sometimes families are calling to find a place to put their loved one who's not well. And I just tell them, mental health doesn't discriminate. It's from the park bench to Park Place and everywhere in between.
Mental health care isn't about other people. It's about any of us who might need help. Yet, Hollywood stereotypes and outdated fears have created a dangerous misunderstanding about psychiatric treatment facilities. On this episode of Beyond the Window, Ventana's Chief Clinical Officer Sharon Volner sits down with Carla DiCandia, Director of Business Development at Oceanview Psychiatric Facility, to separate fact from fiction. We'll expose the truth about forced medication, walk you through a real day in treatment, and reveal what psychiatric care actually looks like when the cameras aren't rolling. This is Beyond the Window.
Welcome to Beyond the Window podcast. My name is Sharon Volner, licensed marriage and family therapist, and you are?
I'm Carla DiCandia. I'm the Director of Business Development at Oceanview Psychiatric Health Facility in Long Beach.
I am so excited to have you here. This has been a long time desire for me. Because I really want to look at tackling this crucial topic of psychiatric healthcare, what it is, what it's not. Psychiatric healthcare facilities have been sensationalized in the media and glorified as these horrific, awful, locked up, one flew over the cuckoo's nest type of places. Yeah. And I really think that psychiatric healthcare really deserves a conversation about what it is and what it's not. So thank you for joining us today.
My pleasure. My pleasure.
So what is your interest? Let's start there. What made you want to work in psychiatric healthcare?
I'd have to say it was not necessarily something I knew was coming. I was working in corporate healthcare at a large Catholic health system, and then fell in love with an alcoholic, and then thought, well, this is interesting, and went to work for a rehab as their director of clinical outreach, and then got recruited to work in a psychiatric hospital. I really didn't think twice about it. I didn't ever stop to be like, oh, a psych hospital. You know what I mean? For me, it was like, it's healthcare. It's an opportunity in healthcare. And so, and I love it. And I've been there 8 years.
And I love that you say that, an opportunity in healthcare, because most people, when you say psychiatric facility or psych hospital, people are automatically thinking an insane asylum, the cuckoo house. People are wearing straitjackets. It's like Girl Interrupted and other movies that have really put a different spin and stereotype and created this fear-based ideal that really isn't true. And so I really wanted to look at today as to what is a healthcare facility or hospital like Oceanview, and what goes on in there. And I have some notes here because there are some really interesting myths out there that I want us to debunk today for our viewers and listeners.
Let's do it.
Okay. So psychiatric hospitals are like asylums from a horror movie, dark, scary, full of screaming, and crazy people. We hear that a lot.
Yes, we do.
What are they really?
These are just people who are experiencing acute psychiatric symptoms, and for a variety of reasons. So disclaimer, I'm not a doctor, I'm not a therapist, I'm not a medical professional. So all of my opinions and things that I share with you today are based on my life experiences with psychiatric patients. So it's all anecdotal.
Yeah.
But they're usually with us because their symptoms have overtaken their lives, and much like I guess how an addiction would make someone's life unmanageable, these symptoms do the same thing. And so now you have somebody, I have major depressive disorder, and I know there are days when I'm not properly taking meds or whatever, or when I've been in depressive episodes where if you ask me to get up and brush my teeth, it's like, oh my God, that's like moving a mountain. The energy, the thought, and it's like, well, my teeth won't fall out if I just skip today, Right. But it's just, it can just be, it can be anything. It can be the racing thoughts that keep you awake at night. It can be, walking down the street and you've kind of cross the line from being vigilant and aware of your surroundings to hypervigilant, like, oh my God, I just walked by those people. Are they talking about me? I don't know them, but what are they saying? And, it's once it's become unmanageable, that's who's in psychiatric hospitals. I will say also, in locked units, I don't work in a locked unit. I work in a voluntary unit. So we don't have police officers or ambulances dropping people off at my hospital. But in locked units where they do 5150s, they do have that. And so it might be somebody who is in a psychosis and committed a crime. Does it mean they're a criminal? Not necessarily. It means they're not well and something went wrong. But yeah, this whole concept of like they're screaming, and I have heard loud persons on my unit. There's one woman who loves to sing, and so she'll be walking down the hallways and singing joyfully. There's another woman who cries, and so you might hear her crying very loudly, but they're human beings.
And you said a whole lot, and I want to kind of like
deconstruct.
Sorry. No. First of all, I love your vulnerability that you're disclosing that you have also and do struggle with depression.
Yeah.
And have times where you're struggling with basic stuff that we should all be doing, right? Getting up, making our bed, brushing our teeth, but sometimes the struggle is real.
Yeah.
And I always love to say that, everyone struggles. Everyone has mental health.
Yes.
Everyone has mental health. It's how are we managing it? And it's okay to normalize the conversation that sometimes we're having a little more symptoms than others, the racing thoughts, or are those people talking about me, or depression. So mental health shows up in a variety of ways, and when it becomes unmanageable and an impairment, it earns the title of a diagnosis, which I really believe if we can name it, we could tame it, kind of like what Dan Siegel says. So that's what the name is for. It's for insurance. It's for medication. If I know this jar is called peanut butter, I know it goes with jelly. I'm not going to put it in something else. But if we can name it, we can tame it. And if we can't tame it, it's not that we're crazy. It's not that we're psychotic, which is literally its own diagnosis of having auditory, visual, or olfactory hallucinations. It's something is off and I need to manage it. And sometimes voluntary hospitalizations can be a safe way as an early intervention so that things don't become worse. So it's not the loony bin and the crazy house and all the extremes that we've seen in Hollywood and media, but it's really, and I've been to Oceanview, so I can attest that it's a beautiful, clean, very well-lit facility with single rooms and group rooms and windows and so much light, and people are singing and people are just learning how to manage their day-to-day struggles with a ton of professionals on site, nurses, doctors, healthcare workers, and it's not these images that we see in Hollywood. Now, sometimes those do exist. Those are generally for the locked facilities where people are in imminent danger of hurting themselves or others. So,
and I will also add that even on those locked units, generally they separate the patient population into high acuity and other acuity. And they might, if they have the space, they might even go as far as to have a low acuity unit too. Yeah. So I don't want people to be afraid, like if you go voluntarily and it happens to be at a locked unit, that you're going to be with the people that the cops are dropping off. That's not necessarily true. Yeah. So I just wanted to clarify that.
Absolutely.
That they're not usually intermixed.
Yeah. And those people also are people that need treatment, just showing up at a different severity.
Right.
And yeah, so
they waited
thank you
too
for
long.
that.
They waited too long.
Some people wait too long or just become, in a state of denial. I don't want to admit. I mean, how often do we get help when the red flag warnings are there, or do we wait when it's a little too late and then we're like, oh man, what do I do now?
Right. Well, even when we look at the statistics for people getting help for depression, I think it's an average of suffering with the symptoms for 5 years before seeking treatment. And that's not even seeking medication treatment. It could be they seek therapy, and then how many years I did 2 years of psychotherapy actively. and I still hold a slight resentment that he didn't ever tell me like, oh, hey, by the way, you have clinical depression. You know what I mean? But and then finally get medicated. But it's on average, it's 5 years.
Yeah. Well, it's nice that today the conversation is being normalized with platforms like this, where we could talk about psychiatric care, mental health care, therapy, medications.
Yeah.
Like, it's all okay. There are so many different options to access help.
Yes.
And if we talk about it and normalize the conversation, more people are likely to get early intervention and help.
Yeah.
Because what we don't want happen is we get to a state where we're isolated, we're paranoid, our thoughts are racing, we're afraid to tell anyone that we're not feeling ourselves, and then it ends up being an emergency admission anywhere.
Yep.
So that is very scary.
Yeah.
So another myth I want to run by you is once you go to a psychiatric hospital, you're locked away and you can't leave, and they force you to stay indefinitely.
Yes. I can't tell you how many times patients, a loved one has called with them and wants them to get help. And aside from obviously my unit being voluntary, so no, you're not locked in. The doors are literally unlocked and you can walk out anytime. But they say, if I go in, they'll never let me out.
Right.
And I've heard that phrase so many times. And it's not true. I mean, the fact of the matter is, even when there are people where I'm like, oh God, I wish we could keep him here longer because he's not well, we can't. It's just, that's just not the way the laws are written. They just can't. So legally, there's a process. And if you go in voluntarily, can they write a hold? At my facility, no. In other facilities, they can. It's usually for 72 hours.
And it's usually if you're in imminent risk of hurting yourself and others. And so the imminent part is very crucial because unless you are in immediate danger
With a
of hurting
plan.
yourself, with a plan,
and intent.
and intent, it's not going to happen. And patients do have rights. Patient can self-discharge, and patients can come and patients can go. And so that 5150 code, which is the involuntary hold, or for teens, 55, 85, sometimes it's voluntary. And
Yes.
it can be voluntary where they can come and go and seek the treatment that they need and leave.
Yes, and I'll tell you, to your point, when people self-admit to a locked unit, but they're admitting voluntarily, sometimes I'm of the opinion that the hospitals write the hold merely for the sake of getting that stay authorized by the insurance. Because the insurance companies don't want to believe that people are checking themselves into a psych unit for treatment. They still kind of view it as like they're just taking a vacation.
I will not comment on anything about insurance.
Yeah, but so sometimes those holds do get written.
Yes.
I don't know much about them,
Yeah.
but even if the doctor said, "Hey, Sharon, you know what? You've been here 3 days and your hold is up, and you're not well. So I don't feel comfortable discharging you, and I want to keep you longer." That's great that he has that opinion, and he has to present that to a judge and or a mediator, whoever's facilitating for that hospital. And that judge has to give approval. And the patient has the opportunity to attend the hearing and advocate on their own behalf. And even then, the judge will say, let's say the judge says, "Yes, I agree with you, doctor. I'm going to extend the hold for up to 14 days. That doesn't mean you're going to be there the whole time. It's entirely up to the doctor in terms of when you discharge. And then if after the 14 days, let's say doctor's like, "Gosh, Sharon, you're still not well. I think we need to pursue additional measures." They can go back, but nothing happens automatically. The patient is involved in all of it. The patient has the right to have an advocate there with them. So this whole you're going to be there forever, it's literally almost impossible. If you're going to be there forever, you'll know well in advance that that's the plan.
Right. So it's not what we see on TV
No.
where people are coming and they're taking you in the middle of the night and you're in a straitjacket and a padded room and you're locked against your will and forget about it. Like, there's an actual process that the patient is a
legal
part
process,
of.
yes.
And absolutely. I love that you said that. A legal process that the patient is a part of, and it's part of coordinating care.
Yeah.
And so thank you for debunking that one. My other favorite myth out there is that people get drugged so they're zombified and compliant.
Okay, so here's the other interesting part. Again, I work in a voluntary facility. So if you and the doctor sit down, you come up with a medication plan.
It's collaborative.
Yes, doctor explains it to you, and you're like, yeah, no, I don't actually like the side effects of that. Is there something else? So it's very collaborative.
And I know that because we've actually, in our residential programs, have assessed clients to see if they're an appropriate fit for our residential programs, because we do believe that care is on a continuum. So if you're in a psych hospital, it is recommended that you seek outpatient therapy or therapy of a residential or outpatient. So I know firsthand that we've interviewed clients that are like, I'm in a psych facility, I'm receiving care, I like the medications that I'm on, but I would maybe like to try alternatives, and I'm open to coming to your program, or I'm open to this. So it's very collaborative. And it's a conversation between the doctor and the patient. It's not that the doctor is always right. It's the doctor's making medication suggestions, and the patient is a part of that process too.
Yes.
And then absolutely the patients and the clients do have a say in their care, when of course it's not an extreme situation. But I also know, back to the previous point about holds, is if a client has a safe outpatient plan, sometimes the holds are kind of lifted early. So... But people are not over-medicated. They're not doing that shuffle.
Well,
they're not.
I mean, there are. I think it's important to clarify this one point. Even if you're on a hold, a 5150, a 5250,
So that's the shorter hold versus the extended hold. Okay.
They cannot force you to take medication. Period. The only time that you can be forcibly medicated, there's 2 times. One, if you're on a hold and you are out of control, you are becoming a hazard to the people around you or to yourself, that's when you hear about people getting taken down and injected against their will. That injection is a sedative, and it's a strong one. And it usually will take somebody out for like a day.
Those are very extreme situations.
Those are very extreme situations.
Yeah.
And so, I hear it a lot where patients are like, oh, and I was at this unit and they forcibly injected me. And, in the back of my head, I'm like, that all has to be documented and justified. So something happened.
And there's cameras.
And there's cameras.
Nurses. And there's staffs. And it's very few and infrequent.
Yes.
Not like what we see in Hollywood.
No,
and in movies. No, of course not.
And then the other time that they can force you to take medications, again, you have to be on a hold, and there's a legal proceeding that is attached to the request. So if the doctor's like, Sharon, you've been refusing medications the whole time you've been on the hold, it's been 3 weeks now, you're not getting better, I'm going to petition the court. It's called a Reese hearing, and it's a whole process, and the doctor and the patient again has the opportunity to represent themselves, but it requires a Reese hearing in order for the judge to say, you know what, the doctor's right, Sharon, you're not making good decisions for your health, and so we're going to take this matter into our hands and medicate you.
Yeah,
that's the only way you're going to be forcibly medicated. So I'm glad you asked that.
Yeah.
Because people really think that. They're like, well, if I come, you're going to make me. No, nobody can make you. Like, even if, no matter how badly we want to, if you need it, because there are those times you're like, oh my gosh, this person would be so much better. Their life would be so much better. But no, there's nothing, we can't do it.
Yeah. So what about the myth that psychiatric hospitals is only for crazy people and only for those that are extremely violent and dangerous? What do you say about that?
I think that's so unfortunate. And sadly, I hear that when sometimes families are calling to find a place to put their loved one who's not well. And I just tell them, mental health doesn't discriminate. It's from the park bench to Park Place and everywhere in between. And I over the 8 years, I can't tell you how many different people, different races, different ethnicities, different sexual orientation, different career paths, different socioeconomic levels, I've had rheumatologists, I've had chiropractors, I've had firefighters, I've had, you name it, lawyers. Like, when it gets to be too much, it's too much. It doesn't matter who you are or where you're at. It's just too much. And it's just like, people also ask, like, well, what kind of people are there right now? The humankind. The humankind with psychiatric symptoms. Does that help?
Yeah.
You know, it's like, what do I tell you? They're all ages. We're 18 and over, so it's across the spectrum.
Yeah. And there's adolescent hospitals too.
Specifically for adolescents.
We're talking about symptoms, mental health symptoms that are far beyond one's ability to manage, that just needs more intervention. So when you talked about chiropractors and other professionals, that leads me to the next myth that psychiatric hospitalizations, just the idea of being in a psych hospital will ruin your career, it'll ruin your life, ruin your reputation, and it'll be something that you're going to be ashamed of later on if you do it.
How will they know? That's my question. How will they know?
Yeah.
Unless you tell them.
Yeah. And it's confidential.
Yeah.
Super confidential. And every client, every patient has a right to confidential care at any level of care, at any facility. It doesn't follow you. It's not on your resume.
That's right.
It doesn't prevent you from fulfilling your life and career path.
No, it's personal health information. It's not, nobody
Protected health information.
Yeah, it's nobody has a right to it.
Yeah.
I know people sometimes worry about like the bigger health systems and, you know, are all of those like hospitals have access to everybody else's records and the other hospitals, and that's not usually the case.
Yeah.
Yeah, my answer to that is, how will they know?
Yeah. So take me through the process. If there's someone out there that is struggling with anxiety, depression, trauma, paranoia, racing thoughts, just something isn't right. Their level of functioning is impaired somehow. Relationships aren't going well. They're not able to function, and they're afraid to come to a hospital. What might they expect from the first phone call to their last day there? Take me through that process, because I know as a healthcare professional, you know, we've called you, we've had you personally sit on the phone with clients for as long as they need it, which is really impressive. 7 days a week, any hour of the day. Yeah. You've been so accessible to tell your story, share your experience, strength, and hope with other people that are also struggling, and say, hey, as an ally, as a person who doesn't just work in a psych hospital or a psych facility, let me tell you about it. Let me tell you what to expect. And when you get there, I'll see you too.
Yeah.
So like that. So what happens after they make that initial phone call?
So anytime you call a psych hospital to find out about admitting, they're going to ask you questions. They're going to ask you, a lot of times they'll ask you, where are you now? What is the address you're at now? And that's for the purpose of if we need to send an emergency unit, not ours, but.
So let's just talk about it. So I'm suicidal, right?
Yes.
And I want to hurt myself. I'm not going to, because I really want to get care. Good. So if I give you my address, are you going to show up with police and, you know, these big people that are going to like put me in a straitjacket and then like take me away? Or is it safe to have that conversation? Like, no one feels comfortable and safe to say, I feel suicidal, I want to hurt myself. Right. These are super taboo conversations.
If somebody has picked up the phone, that's the indicator that they're open to having that conversation. Okay. Right? So when they call us, we're having a talk about, well, what are you experiencing? Okay, well, you know, I want to harm myself. I don't have a plan, but I hate feeling like this, blah, blah, blah. Then they're probably going to ask you for your insurance information to make sure that you're not getting yourself into a financial bind.
So this is covered by insurance too?
Yes.
Wow.
Yes. Even Medicaid, in California's Medi-Cal, covers it. I mean, this is a health condition, right? You need to be hospitalized. So they'll check your insurance to verify that it's active and in network or has out-of-network benefits. And for us, we do a phone assessment. It's brief, maybe 15, 20 minutes, where we just start asking about the symptoms. And we start asking about your history of, specifically for us, violence. We ask, do you have any legal cases pending? And that's for the sake of, like, if you were to admit, then what what do you have scheduled in the next 7 days? Are you supposed to be appearing in court? Can you do it on Zoom? So they might ask you that. They'll ask you if you're taking medications. If you are, they want to know which ones, how much. I think that's going to be the phone call. And then some hospitals will tell you, okay, well, come, you have to admit through the emergency room. So go to the ER, check in. For us, we like to schedule the admission. So we'll ask you, like, Sharon, well, what time would you like to come and what day? Well, you'd like to come today, but you don't want to come until 10 p.m. No problem. Do you have transportation?
Wow.
And I don't know which other hospitals offer that, but for us, we would ask you, do you need transportation? Are you local? If you're local, we can send one of our drivers. And then we schedule the pickup. And
That's
then
awesome. Because some people, for them, transportation is a barrier.
Yes.
And, where am I going to park? And am I even safe to drive if I'm not feeling like this?
Or I can't drive.
Or I can't
because
drive.
I'm paralyzed by my fear or my anxiety.
Yes.
Or I've had cases like that.
So a 15-minute interview over the phone, and then you set up transportation.
Yeah,
and
we do end up having to send all of those notes through our clinical review, and it gets approved, and then we schedule the admission.
Yes.
Yeah.
And so the person arrives, I arrive, right? I'm the patient, I arrive. What should I expect as far as, where am I sleeping? What am I eating? Who am I meeting with? When do I see the doctor?
Yeah. So
who's there? What other people are there?
Yeah. Most psych units don't give tours to patients ahead of time for privacy reasons. So what I like to say is, you know what? There are all ages and all kinds, and you will find your tribe. And inevitably they do. Just inevitably they do. You will sit down with an admissions or an intake person and do all of the formalities. But I understand I'm here voluntarily. I understand I can leave. Again, this is just at my facility. But like any hospital intake, if you were checking in to Providence for a heart surgery, you show up to the admissions office and you fill out all your papers. Right? And you have a copay and you pay your copay. And then once the paperwork is complete, the additional steps we take in behavioral health is they go through your belongings to make sure that there's no contraband.
What would be considered contraband like?
Anything that can be used to hurt yourself or someone else. So that's why you hear of like no shoelaces, no drawstrings, no belts. Well, but I'm not suicidal. I'm not trying to. Yeah, but we want to make sure not that just you're safe, but that everybody else is safe too, right?
Okay.
No razors, no scissors, no mirrors. So we do, every morning there is a grooming session. So then like if you wanted your makeup, you'll get your makeup and you can do it. And then we're going to take it back and put it away.
Okay.
What else is contraband?
What about activities and meal times? What does that look like?
So
are there activities?
Yes. And while I'm not familiar with compliance and regulations to the T, I will say that the hospitals are supposed to be providing groups, psychoeducational groups. They're supposed to be providing meals and snacks. They're supposed to be providing case management. So like for us, there's, I think, 6 groups a day.
Wow.
So 3 are psychoeducational and 3 are therapeutic recreation.
Wow.
And everything is led by clinical staff.
Wow.
And that means everything has a purpose, a goal, things get charted. It gives the hospital or the facility an opportunity to see the patient in their completeness, right? Because a lot of times patients are smart. They're very smart, and they know what the doctor wants to hear in order to let them go. So maybe Sharon tells the doctor, "No, doctor, I am not hearing voices since you started me on the medication. I'm ready to go home." But then the doctor looks through the chart and sees that the rec therapist has added that today in group, Sharon was sitting next to an empty chair and having a conversation.
So it also gives an opportunity for different types of interventions.
Yes.
And group offers an opportunity for that common ground where people are coming together and sharing, which also normalizes the conversation of, I'm not alone in the struggle.
Absolutely.
And it's okay if I am experiencing voices or visuals and hallucinations, and I could talk about it and I can get treatment. And that's actually not the criteria for a hold. It's, am I safe in my body?
Yeah.
Am I safe in the world?
In the world, yes.
Right.
Big time.
Okay.
Big time.
So groups and meals, and what about meeting with the doctor?
So the goal of being in a psychiatric facility is to get the brain chemistry regulated, right? Like that's the goal. Most places are not offering individual therapy because it's really just not indicated. Right. If somebody's really fragile or really unstable, then it's not, CBT is not going to help.
Well, it's emergency stabilization.
Right.
Yeah.
So they meet with the doctor every day. And this is like standard. In any hospital, you're supposed to meet with the physician within 24 hours of your arrival. And they'll do a psychiatric evaluation. And then the doctor will develop their medication plan for you and discuss it with you. Once you guys are in agreement, they'll put the order in, and then, if it's an AM med, you'll get it the next morning. If it's a PM med, it depends when you see the doctor, obviously,
right,
and what kind of med it is. But and then the doctor comes back the next day. And what's happening a lot of times because of the shortage in physicians is they're using a lot of what they call extenders. So that could be a physician's assistant, it could be a nurse practitioner, but they're prescribers and they're working under the doctor's supervision. So the doctor's developed the plan. Or maybe you showed up and it's that doctor's day off, and so you're actually meeting with the extender. That person will develop the plan and, give it to the doctor and get you started. So there's no waste of time while you're with us, right? And then the doctor comes back the next day and is like, hey, Sharon, you came in, you hadn't slept in 4 days. We started you on Seroquel last night. How did you sleep? Oh, I slept really good, but this morning I woke up, I was really groggy. I just couldn't snap out of it. Okay, well, let's make an adjustment.
Oh, wow.
Right? And so, and that's the advantage. I think many people who've been on the mental health journey, specifically with medication, you go as an outpatient person, you go to your doctor and you're like, I'm not sleeping. And when I am supposedly sleeping, I wake up exhausted 10 hours later. And every day I come home and I'm sobbing. I mean, this is my story. Every day I come home and I'm on the floor with my dog sobbing and la, la, la. And the doctor's like, oh, okay, sounds like depression. Let's start you on this medication. And, it's going to take a few weeks before it kicks in. So don't have very high expectations of noticing anything immediately, and then come back in 3 weeks and let me know how it went. And you're like, well, shoot.
That's so much time in between. So here you're getting to see a doctor or a practitioner every single day. And so you said hospitalizations are not indefinite stays. So how long is a hospitalization when we're talking about acute stabilization, triaging?
Yeah.
What can a person expect?
For us, it's about 7 to 10 days.
Okay. Could it be shorter?
It could be
longer?
Yes.
So it's really individualized to what does the person need. If I'm coming in and I haven't slept in 4 days and I'm still not sleeping in four additional days, is there opportunity to stay until we find the right med? Because I know that is a huge concern with patient care. Yes. Is I don't want to see my doctor in 3 weeks.
I know.
That's so long.
It's so much suffering.
And it is so much suffering. And what do we do in the midst of suffering? What other bad behaviors, or as TJ Woodward says, brilliant strategies, do we come up with in the meantime? So it sounds like a really collaborative process where I want to find the right med. I don't want to leave. Because the fear of, I'm going to go home and I can't do another night awake. I just can't.
Yeah, no, absolutely. And same thing with when you're looking at, for example, medications that require blood tests to make sure that you're reaching a therapeutic dose. We do that all internally. So it's not like, oh, okay, Sharon, outpatient, start you on Depakote. We're going to start you on a low dose and come back. And then, you know what I mean? It's like that could take weeks. This is going to happen within a week or two.
Wow.
And when we hit that therapeutic dose, then we see how that goes. If it's too much, you know what I mean? It's it's all happening pretty immediately. I mean, in the grand scheme of things, it's immediate, you know?
So let's say a person checks into a hospital. Are they able to call or visit family.
Yes. So the law says that a person in a psychiatric facility must have access to a telephone 24/7. So there will be patient phones on any psychiatric unit because it is required by the law. And, you can't have your cell phone, and that's kind of standard. And there's a lot of reasons why, but you can make calls 24/7, and you can receive calls too, if you have people, on consent and all that good stuff. The visiting hours, don't know what the regulations are. I know a lot of the locked facilities have visiting hours every day, at least for like 2 hours in the nighttime. For us, we do visiting on Saturdays and Sundays from 1 to 3.
So there is family contact.
Yes,
There is engagement.
absolutely.
Yeah.
I'll also want to touch on when you're talking about like accessibility to patients or staff. I just heard this again this morning from a family that it was really hard to get a hold of the doctor while my loved one was there. And yes, it's true. And I'm going to say that that's the case pretty much in any hospital and really like almost on any unit. And it's because the doctors are not our employees. So they come on their own schedule. Many of them are privileged at a number of hospitals. And so they're making rounds at a couple of different places a day. And then depending on how long it takes them.
But there's social workers and case
There are
managers. I know
social
that.
workers, there's case managers, there's the nursing department.
So there's always someone to talk to.
Yes, if you call the nursing unit wherever your loved one is and just say, can you check if I'm on consent? And if you are, ask, what have there been any medication changes? Like what are the notes saying? How are they attending groups? Are they eating? Are they, you can ask all those questions. It's all in the system. And if it's not, then there's staff there who know your loved one. Like we spend a lot of time, the nurses and all the staff at the hospital are working 12-hour shifts.
Yeah.
So that's a long time with people, and they get to know them pretty well. So I know when I go to visit patients, I try to with their permission, take a picture of us together and send it to the family. So they're like, okay, this is what he looks like. He's here. He's okay. But.
And you personally have a relationship with patients and families.
I tend
because I know
to.
that.
Yeah, I tend to. It's just because for me, I try to be who I would have needed.
Yeah.
And I recognize that they're sending their child, their wife, their mom, their brother, they're sending this person to what you've identified clearly as a very scary situation.
Yeah.
And nothing pleases me more than hearing, for example, a mom that I spoke to this morning, she told me, I'm so glad that we went because she felt safe. It did her so well. The doctor, the medication, to know that we can be that place for someone at literally one of the most vulnerable points of their entire lives. There's nothing, I think, more sacred than that. So yes, I try to be involved when I can.
So what would be your one piece of advice for the listener out there, the viewer out there that is concerned about their mental health, but they're so afraid of the stigma because we stigmatize what we fear and don't know, and have been recommended to seek treatment or seek care at a facility of any kind, and just the idea of the facility, a hospital.
I know.
What would be your piece of advice to someone out there listening that is aware that something is going on and they might benefit from accessing care?
I think I would say if you don't do anything, it's not going to get better. And with mental health, it tends to get worse. So try it. You can always leave, but try it. And I feel the same way about medication. A lot of people are hesitant about medication. Well, I don't want to be on medication. Okay, it doesn't mean you're going to be on it forever. maybe you just need to get through this period of time, like this difficult period at work or this difficult time of loss or something situational, and you just need help to get through it for now. It doesn't have to be forever, right? Those would be my two things. Just try it because it's going to get worse, and it doesn't have to be forever. That's it.
Thank you. So what haven't we covered as far as any stereotypes or myths that need to be debunked?
We talked about medication. We talked about
medications, holds.
Yeah.
Scary, dark, screaming places.
I think the other thing people are afraid of is use of force.
Yeah.
Right? So it's kind of like any other situation where if you don't need to be restrained, you won't be. And there are always interventions first. You know, if you, let's say, are starting to ramp up, we have a whole protocol at the hospital in terms of observing patients on the unit when nothing is happening. And then that way we can see, Sharon has started pacing. Okay, so that's a sign, that's an alert for us, like Sharon is experiencing something.
Yeah.
So a social worker might go out and be like, hey, Sharon, I came out to see you. We want to chat, check in with you. You're like, I'm fine. Okay. And then you keep pacing. And now you're pacing faster. And now your facial expressions have changed. So now we're more concerned. And somebody's going to come out, probably the nurse and the social worker, and say, hey, Sharon, we're worried about you. Can we give you something to help you relax or feel better? Do you want, you put on your form when you admitted that music helps you to calm down. Would you like a headset?
Wow.
We offer these interventions, and Sharon has the right to say no. Okay. So now Sharon is pacing, she's got the face, and now she's starting to ramp up verbally. Okay. Then we're going to go, maybe we send the doctor if he's there, or the staff. Someone's going to come to you and be like, Sharon, we're very worried. We've offered you this, this, and this, and you've not wanted it. And I'm just going to really strongly encourage you to help us help you. Because if this keeps going, then we're going to have to call for a third-party evaluation, which is a PET team. It's a county
psychiatric
unit
evaluation team.
Yes.
Yeah.
And if they come and they decide that you're a danger to yourself or to the other people here, they're going to take you on hold. And when that happens, I can't get you out. I can't get you back. I mean, it's like you're going to another hospital at that point.
So we're going from the least intrusive to the most intrusive, but there's so many interventions. You talked about music and social workers and nurses and coping skills and groups and just
we try everything.
So much that is not common knowledge.
Yes. Yeah. Yes. And then on the rare occasion that Sharon's like, you know what, F you, F all of you, I don't want any of that. And now Sharon's throwing chairs. Okay, that is 100% unacceptable.
Right.
So let's say you make some kind of gesture, you do something that shows us that you're trying to hurt yourself, someone else, right? That's when we have to intervene physically.
Right.
Again, we have a very strict protocol because we are hands off. So if in other facilities too, if we put hands on somebody, that is going to require a whole bunch of paperwork, a whole bunch of justification of why, right? Why we don't want to do that.
Because patients have rights. We're going from the least intrusive to the most intrusive, and really the most important is safety and care.
Yes, and if we have to protect you from yourself, we will.
Yeah.
But there's always going to be a whole bunch of stuff leading up to that.
Yeah.
Again, I've only worked at Oceanview, so I'm speaking from my own perspective. There might be people out there who are like, that's not true, that's not true. And maybe in some circumstances.
And it's not true for all other hospitals. Right. And what I love about Oceanview is that it's a private hospital it is voluntary. There are many other hospitals that we have worked with and have wonderful relationships with that have locked and voluntary, and a lot of the themes are very similar across the board.
Yeah.
Everyone has a bad story
Yes.
about a place, much like if we go to a coffee house and someone didn't make our drink correctly, that happens everywhere. But it's not as common as media sensationalizes it. It makes for great TV drama, but it's not in real life.
Yeah.
And it's really wonderful and a privilege to have this conversation because so many people don't know what to expect. And the idea is so scary. And for any of our viewers and listeners, and I'm sure some of our clients are going to be listening and saying, I can attest to that. And I wish I knew. And it's just so nice to have these taboo conversations that no one talks about in the world about, let's talk about suicidality. Let's talk about mental health. Let's talk about symptoms. Let's talk about the impairment that does take place that people don't talk about.
I know.
Until it's too late and it's so secretive and isolated and stigmatized. And we don't need to do that. We can access good healthcare, good medical care without the stigma.
Yeah. And, to kind of, I just had this afterthought about when you asked about privacy and will people know. Another question that comes up a lot is, well, I can't miss work. I need the money. All of us do, right? So in those situations, we can write a letter. The doctor can write a letter for your medical absence. And it's not going to say from Oceanview. It's not going to say I'm a psychiatrist. It's going to say Sharon is under my care. And and he'll put in there why you can't return, well, not why like in detail, but that you cannot return to work based on his treatment plan.
A very discreet letter. Unable to work at this time, and it's an excused absence from work, and it is 100%
real.
Valid.
Yeah.
Yeah.
Exactly. So I know people are like, well, I don't want my work to know. And it's like, no, they won't know.
Yeah. Nobody has to know.
Yeah. Yeah. We try to remove all the barriers.
Yeah. So final thoughts.
Thank you. Thank you for thinking of this topic and bringing light to it. I'm sure people have other questions. If you ever get any other questions and you want to talk about them, let me know, because the more
follow-up segment.
Yeah, the more people know, the better off we'll all be. Yeah.
Thank you so much for coming, Carla.
Thank you.
Thanks for joining us for this important conversation. If you want to learn more about Oceanview Psychiatric Facility or connect with Carla DiCandia, visit www.ovphf.com. And if this episode changed how you think about mental health care, share it with someone who needs to hear it. For more raw, real conversations about breaking stigma, subscribe to Beyond the Window wherever you get your podcasts.